Can others hear this okay on Zoom? Good morning.
How are you?
I'm well. How are you, Greg?
Not too bad.
Pleasure to see you.
I'm just always happy that I can find places.
Well, thank you so much for coming.
I'm still a stranger in a strange land here. I feel like.
Well, we're glad to have you.
Parked right out front. It's a piece of cake.
Good deal.
So,
Good deal.
that's it.
You found a spot on Floyd Street?
I get basically right in front of this building. I saw what the building looked like online.
Okay.
Because there were several metered spots.
Perfect.
I don't know what street it was.
Okay. Probably maybe
No, it must be. What's the address you
we'll just
gave me?
need to retrace your steps.
That's exactly right. As I was coming into the basement, I thought, well, this could be an issue. What was the address you gave me?
I gave you two. One was Chestnut Street Garage, and the other was the actual Baxter Auditorium. And I think it's
I think I'm on whatever.
Preston,
Yeah. I think I'm on
One Way Street.
Yeah.
That would be Preston. That's good. Preston's good.
There was a meter that took my change.
That's all. You met all the requirements.
We'll see. I may be taking an Uber back home. Should be okay.
So what, I've just run through data for about 30 to 40, 30 to 40 minutes. I'm gonna go through kind of fast. I usually do one slide a minute, but I've got 57 slides, I think. So I'll be talking fast. And then we'll just open it up.
All right.
Remind me when you change.
I'm in Iowa, University of Iowa.
Awesome. It's easy to remember, so.
That was easy. Hawkeye?
Yeah.
My wife never forgave me for leaving Iowa. She loved it out there.
It's a cool place.
It's, remember going out there thinking, and it turned out we liked it out there.
Well, there's lots of research that comes through the VA group that's affiliated with
My advisors at the time were trying to encourage me to go to places like Columbia. And I was married to a Hoosier farm girl, and the idea of a big city terrified her. So Iowa was a good compliment for her. But it had your son in it.
So he undergraduate. So he was interested in creative writing.
Oh, yeah, fantastic.
So he,
Which is also fascinating, in the middle of Iowa.
yeah,
World famous creative writing.
a niche of excellence. But yeah. It's so he wound up then moving to Montana. He's a paramedic in Montana.
No. That's pretty fascinating.
What was the Alzheimer base behind it? Iowa, and now in Boston.
Greenberg, Steve Greenberg.
Was he in Iowa?
No, actually, no, I'm mistaken. He just had a connection with us. None of the.
This guy written like.
That's terrible. He was gone before I got there. I know. It's too far back in the mix for me to remember. I actually went out there, studied with Nazios in the cognitive neuroscience. I've never intended to be a clinician. And then as I was finishing up training, I like being a clinician. I went the wrong direction. But no, I can't think of who that is. We've had a few good people come. Neil Graff, Mayo, Liana Pasquale, who was a resident. Unfortunately, I hate to say this about it, I think it's the program that was 20 years ago. I think it's solid. That's not what it was back in the day. That's what bothering me all this. Thinking about who was what. The neurologist who was the chairman there.
Well, I saw him sitting here and
Tony Pinocchio was just in there 30 years ago. Before that, what was his name? Right, I can't remember the order of it. They don't.
I trust it there.
One of them was fascinating. Yeah, I don't remember which one. I should know history better.
I didn't know
It
there
was
was.
neurosurgeon. Then he tried to turn it neurology. It ended up becoming chair.
Really cheap.
There's songs of Van Allen, I'm not sure.
There's always like really
Uh,
school stuff.
It was kind of an interesting history. Pretty long history.
School in this section.
Do you have a connection with the group out there?
I got you.
I don't remember.
I've been calling you.
Oh, hi, Chris.
How are you doing? See you.
I was trying to encourage.
Nice. Good to see you.
How are you?
Haven't seen you for a
I
while.
know, it's been a while.
Trying to keep all your guys' area of the world, you know. So hoping I was just upstairs waiting for Greg to come in. I kept calling him, he had his phone on mute, so I thought, maybe he's down here.
Okay.
Either that or.
You have to turn it off. That's all.
Change my number on it.
Yeah, been trying to do that for 2 years now.
By the way, I got set up for some kind of lunch.
We might go ahead and get started, I guess.
11:30.
So good morning. Can everybody hear me okay, including the folks on Zoom? I'm not sure about the folks on Zoom. We'll find out. So I'm Mike Sowell. Dr. Friedland and I thought we would prepare this topic for Grand Rounds, and we have surprise guests that I will introduce a little bit later to discuss further on the data. So my intent is over the next 30-40 minutes to present the data and leave us plenty of time for discussing the evidence. So now I'm advancing the slides. There we go. So I'm mainly going to be talking about this article, Lecanemab and early Alzheimer's disease, and which was published actually in January in the New England Journal. But as many of you know, the drug has now been fully FDA approved as of, I believe, July the 5th, and opens up kind of a new area for discussion, but we'll talk about kind of the evidence that led up to its approval. So we're going to examine new pharmacotherapeutic options for management of Alzheimer's and add to the best practices in the treatment of Alzheimer's disease. So the notion is that there's accumulation of soluble and insoluble aggregated amyloid beta, which may initiate or at least potentiate the pathologic processes in Alzheimer's disease. Lecanemab is a humanized IgG1 monoclonal antibody, binds with high affinity to the soluble or protofibrils of amyloid beta, and is tested in persons with early Alzheimer's disease. So that's what this article is about. So the concept is that there is first accumulation of amyloid. So going from left to right, the ATNC is amyloid, and then tau is visible on a PET scan. And then you have neurodegeneration as evidenced by brain atrophy as well as brain hypometabolism. And then the C is cognitive impairment, which is kind of the end point of that, which results in other functional impairments as well. So Clarity AD was an 18-month multi-center double-blind phase 3 trial involving persons 50 to 90 years of age with early Alzheimer's, either mild cognitive impairment due to Alzheimer's or mild dementia due to Alzheimer's. And we'll talk about those definitions briefly. But evidence of amyloid on PET or by CSF testing, enrolling in a 1-to-1 placebo-controlled randomized double-blind trial, and 3 optional sub-studies looking at longitudinal changes in brain amyloid as measured by PET, brain tau pathologic features as measured by PET, and then CSF biomarkers of Alzheimer's disease. So the trial included people 50 to 90 years of age, either mild cognitive impairment due to Alzheimer's or mild Alzheimer's. The criteria used were the 2011 papers on NIA Alzheimer's Association criteria. And amyloid positivity was then determined by PET or CSF measurement of amyloid beta. And all participants then had a number of neuropsychological testing to confirm the diagnosis of either mild cognitive impairment due to Alzheimer's or Alzheimer's mild dementia. We'll talk a little bit. So these are the papers that 2011 were published, kind of a committee looking at what constitutes mild cognitive impairment due to Alzheimer's disease with various domains. So core clinical criteria, and I won't go too deeply into this, but these were the core clinical criteria that were derived and we used as the framework for this study. Basically looking at also MCI consistent with AD, Alzheimer's disease pathophysiologic processes as well. And this paper was then on the diagnosis of dementia due to Alzheimer's disease. And patients that were enrolled were patients with mild dementia, not moderate or severe. So criteria on the diagnosis of dementia due to Alzheimer's disease then has a proposed classification scheme, core criteria, probable, possible, considerations about biomarkers, as well as pathophysiologically proven Alzheimer's disease dementia. But basically the main distinction between dementia and mild cognitive impairment is interference with ability to function at work or usual activities, a decline from previous levels of functioning, not explained by delirium or a major psychiatric disorder. And then cognitive impairment is defined involving a minimum of 2 of the following 5 domains. So impaired ability to acquire and remember new information, reasoning, handling complex tasks, and poor judgment, impaired visual spatial abilities, impaired language functions, changes in personality, behavior, comportment. So the primary endpoint used the clinical dementia rating sum of boxes, CDR-SV, ranging from 0 to 18 with higher scores indicating greater degree of impairment. And then secondary endpoints that were examined included changes in amyloid burden, and then 3 different sort of neuropsychological outcome measures looking at the Alzheimer's Disease Assessment Scale, or ADAS COG-14, so the cognitive portion of that scale. And then the ADCOMS, which is Alzheimer's Disease Composite Score, which has a more narrow range, 0 to 1.97. And then the more of a functional, looking at activities of daily living, Alzheimer's Disease Cooperative Study score. I'm not going to go too deep in the weeds, but I'm just going to expound a little bit more on the 3, on the primary endpoint, and then the 3, the secondary endpoints. So the CDR sum of boxes was developed at WashU in St. Louis, yay, WashU, in 1979, so before I got there, for evaluation staging of severity of dementia. And with the outcome, you get a scale from basically 0.5 to 3, or 0 to 3, really. And I'll show you what that looks like. So you basically, this is a 79, so this is a paper format, but looking at different domains. So the domains are memory, orientation, judgment, problem solving, community affairs, home and hobbies, and then personal care. And so you have then, for each of these domains, you have a Likert scale of degrees of impairment. And then you literally sum up the boxes. So it's just simple math, numerical summation. So that was the primary endpoint. The secondary endpoints, the first one was change in amyloid burden. So on the left, at the top, you see a PET scan with radio labeling targeting amyloid. And the top left is normal, the bottom left is abnormal. Kind of ignore the 2 right pictures. Those are tau, and those were not necessarily looked at. And then the second was the Alzheimer's Disease Assessment Scale. Let me move this thing out of the way. Anyway, the cognitive portion of it. So it was developed in 1984. Primary cognitive outcome measures. It's what the FDA requires for any clinical trials that involve Alzheimer's disease in the United States. It has various domains. The scores range from 0 to 70, and is shown to be successful in not only identifying Alzheimer's patients from healthy controls, but also effective in rating severity of the Alzheimer's between moderate and late stages of dementia based on decreasing performance and various orientation items. So it has 11 domains. So word recall commands, you can kind of read that, but constructional praxis, naming, ideation, orientation, word recognition, remembering word recognition test instructions, comprehension of spoken language, word finding difficulty, spoken language abilities. And this is from a paper actually comparing kind of the outcome domains of various tests for Alzheimer's disease. And you can see in the middle is the ADAS-COG items, and it's a much broader basis or framework for determining Alzheimer's. On the left is many mental status exam, which we really don't use too much anymore, but it has 7 outcome measures. And then the CDR sum of boxes has only 6. There was no mention of MoCA, which is probably what is most commonly used as a screening tool anyway for memory impairment. The third secondary outcome measure was the ADCOMS, which is Alzheimer's Disease Composite Score. It's scored from a range of 0 to 1.97, so we'll talk about that a little bit. Again, the higher score, the indicative of worse impairment. And then the fourth outcome was the ADCOMS, Activities of Daily Living Scale for use in mild cognitive impairment. And it can be completed by the caregiver or the examiner or the clinician. Researcher is supposed to be reflective of the last 4 weeks in terms of outcome, and has different domains that it examines. And it looks something like this. So it's actually, this is just one page of, I think, 8 pages or something, a similar sort of outcome scale. I'm really not a statistician, so I'm going to really kind of go through this quickly, but essentially the numbers were, or the sample size was targeted towards a meaningful outcome being 25% less decline in cognitive function, targeted to try to achieve a 25% less decline in cognitive function with the active compound. So a total of 1,795 participants enrolled, roughly equal groups with lecanemab and placebo. The mean CDR sum of boxes score at baseline was 3.2 in both groups. Adjusted least squares mean then was 1.21 with lecanemab, 1.66 with placebo as an outcome. And then in various sub-studies, the amyloid reduction was quite significant, and I won't go too far in the weeds. There were significant adverse reactions, and I think that's where we have a healthy academic debate. Is there was a 26% risk of infusion site reaction, strangely 7.4% with placebo. ARIA is a new concept. So ARIA stands for amyloid-related imaging abnormalities, and those include ARIA-H and ARIA-E. ARIA-H is microhemorrhages, cerebral macrohemorrhages, or superficial siderosis, which is accumulation of blood on the surface of the brain. And then ARIA-E is, the E is edema. So ARIA-H was 17.3% with lecanemab, 9% with placebo. And then ARIA-E was 12.6% with lecanemab, 1.7% with placebo. But then headaches occurred in 11% of patients with lecanemab, 8.1% with placebo, and then falls at 10% with lecanemab versus 9.6% with placebo. So there, is some debate in the kind of the after spin, I'm going to say, the editorial comments and opinion papers following this study about some of the demographics at baseline. There was perhaps an underrepresentation of minorities, for example. And I kind of just highlighted that. This is kind of a busy slide, so I'm not going to go over all of it. They did use the MMSE, and strangely, the MMSE scores at baseline were 25, which is not too far outside of normal, but we do understand that MMSE is fallen out of favor as any sort of screening test for memory impairment. And this is also a busy slide. I think it's a little bit better represented by some graphs that I'll show you, but essentially this is a primary endpoint looking at lecanemab versus placebo. And these are the secondary endpoints. So this is just the raw data, but then graphed out, you see separation from placebo represented by the blue line versus lecanemab on the primary outcome, which again, this is the CDR sum of boxes, and these are the 4 secondary outcome measures, and you see separation from placebo, particularly in terms of amyloid burden, pardon me. So lecanemab and the monoclonal antibodies are very efficient at removal of amyloid.
Could we see that again?
Yes, of course.
So the thing to point out here is the y-axis is not representative of the data. If they had it for ADAS called the total thing maybe separately points. So there's a difference there of 1 or 2 points, which you can see when you plot it in this manner. But if they plotted it against the 70 points, it would be 2 lines would be identical.
Yeah.
Same thing with the other measures.
Yeah.
All these graphs are manipulated to emphasize the significance.
And then, as I mentioned, adverse events. So any significant adverse events, 44% versus 22% in the placebo group. So again, ARIA is not specific to treatment. ARIA occurs, it's Alzheimer's-related imaging abnormalities, not amyloid-related imaging abnormalities. It occurs in patients with Alzheimer's, but at a higher frequency in patients on lecanemab. So you can see the infusion site reactions, more than a fourth. And then the hemosiderin deposits, the ARIA-E, and then ARIA-E here and ARIA-H, so significantly higher percentages than placebo. So either ARIA-E or ARIA-H was 21% of patients. So more than 1 in 5 received or developed some ARIA abnormality, either ARIA-E or ARIA-H. And a smaller percent had both at the same time, so 8.2% versus 1% placebo. This is what ARIA looks like. So there are various abnormalities here. I believe this is obviously edema, and you see even some effacement of even the frontal horn, the lateral ventricle, but certainly the occipital horn is obliterated on the left. This is also some edema, but I think this is some hemosiderin deposition, and this is, let's see, this is microhemorrhages that are shown. I'm sorry, this is the microhemorrhages, and this is the edema, and then this is the superficial siderosis that is seen. So this on gradient echo is some hemorrhage. So change from baseline at 18 months in the CDR sum of boxes was less with lecanemab than with placebo. Again, as distinct from maybe other trials, and particularly as distinct from migraine trials, you're looking at improvement in symptoms. Your outcome you're looking for here is slowing of cognitive decline. And so in the treatment group, with lecanemab, did favor lecanemab. The results for the secondary clinical endpoints were also in the same direction. The amyloid positivity, actually, it cleared amyloid below the threshold for detection. So they're very, the drug is very efficient at removing amyloid. And the ARIA, as I mentioned, 12.6% of the edema, 17.3% had the hemorrhage, and overall 21%. And the incidences of both the overall and the symptomatic ARIA-E were highest among those who had an ApoE epsilon 4 homozygous phenotype. So genetic testing in one of the subgroups revealed a higher risk of either type of ARIA, but basically ARIA-E in particular. Additional potential limitations was the use of a modified intent to treat analysis. And as I said, I'm not a statistician. I think modified intent to treat is maybe not quite as good as a pure study, but I can't discuss it more in depth. And then occurrences of ARIA may have actually caused the participants or investigators to be aware of which group the patient's in. So there may be this fulfillment effect. So this is what the prescribing information looks like. I guess when I was in training, we called it a package insert, it's PI anyway. And this is the dosage and administration information, but then you also have a big black box warning about amyloid-related imaging abnormalities and a predilection for those who are ApoE epsilon 4 homozygous. And then antithrombotic medications. So were allowed in the study if the patient was on a stable dose, and antithrombotic medications did not increase ARIA with Lecanemab. Once you develop back basically the prescribing information, you can use the trade name of the drug. I've learned over the years. Some of the intracerebral hemorrhages were greater than a centimeter in patients taken, can be additional caution exercised. And considering, caution exercised when considering the administration of anticoagulants. So the question to me is, well, did they come down firm in one direction or the other? If the patient's on Lecanemab and they're on a continuing protocol, should they receive TPA if they come in with a stroke? Sorry. And then presence of an ApoE epsilon 4 allele associated with amyloid angiopathy with an increased risk for hemorrhage. So there is suggestion that in clinical use, probably ApoE should probably be performed. The prescribing information does not, however, address how do you translate this information into clinical care, adjust clinical practices, workflows, use the agent safely, present potential benefits and harms to patients and care partners. So in the perfect world, we would have a complete and balanced presentation to patients of what are the risks and benefits. Most patients aren't neurologists, so it's not exactly equal, but in any case, there's no particular guidance on how do you present that information. I'm going to talk briefly about Donanemab. Donanemab is another monoclonal antibody sort of in the pipeline. I think it's still in the pipeline, but I'm going to just breeze through the data real quickly. The study is called Trailblazer ALS 2. It's a similar sort of randomized prospective controlled trial. Interestingly, they originally designed it as a phase 2, but then later retrofitted it to be a phase 3, which is kind of goes against the grain just a little bit. But and they had to modify the age range, right? So 60 to 85 instead of 50 to 90. But similar enrollment criteria in terms of mild cognitive impairment or Alzheimer's disease of mild dementia. Also assessing amyloid, and then their key outcome measure was a different neuropsychological study that has to do with activities of daily living, and I'll go over that briefly. They also looked at some other similar, they used ADAS-Cog 13 instead of 14, I think it's just a version. And interestingly, they used MMSE as an outcome measure. I think most would agree that that's a bit of an outmoded thing. MMSE was still in use when I was a resident, but I won't go. So IADRS is an integrated assessment of the cognition and daily function from the 13-item cognitive subscale of the Alzheimer's Disease Association assessment scale, or the ADAS-Cog14, and the Alzheimer's Disease Cooperative Study. So it's instrumental activities of daily living, measuring global disease severity across a continuum. And they had similar outcomes for certainly removal of amyloid, and their neuropsych outcome measure did show separation from placebo substantially. And this is some other graphs looking at outcome measures, but they had a very higher rate of ARIA in particular, approaching any ARIA was 36%, so more than a third of patients. So I'm not really sure this drug is going to be approved. I don't, ain't over till it's over, I suppose, but one could debate that. There's also a much higher risk of death with Donanemab and other adverse events. And this is a comparison. So Aducanumab or Aduhelm was approved actually in, I think, 2021, I believe, but only for limited use, and we did not choose to employ administering that here. But this is a comparison between the three drugs, so Aduhelm, Lecanemab, and still under investigation, Donanemab. And you see that cognitive slowing is improved versus the placebo group. I'm sorry, not improved. It's doesn't slow down as fast. Is the best word to put it. But amyloid removal is quite efficient with all three drugs. And then ARIA incidence rates. This actually is this is from another study, kind of comparing them, but 36% was the raw data. Actually, I'm not sure where they got 33. And then ARIA of any sort, as I pointed out, was 21% or thereabouts. And pretty high with Donanemab as well. So, Dr. Friedland, did you want to comment a little bit about these infographics? This one is on the Lecanemab, and starting at the left, so measurement and meaning. So the CDR sum of boxes, there's normal and then mild, moderate, severe dementia. And they did enroll 1,700 or so participants, but you see that adverse events occurred in about 45% total of participants. And this is separation from placebo, I think, on the one measure that has a very narrow range. But interestingly, brain volume changes occur. So you actually have some acceleration of brain atrophy beyond what is expected for aging with Lecanemab. Similar, this is Donanemab. This is kind of a real similar infographic, but also acceleration of atrophy of the brain. So who should receive Lecanemab? Well, certainly persons 50 to 90 years of age. It's not been tested in patients that are 45 with memory impairment. Mild cognitive impairment or mild dementia of Alzheimer's disease, certainly. MMSE of 22 to 30 were required in the phase 3 trials. Evidence of amyloid on PET, positive amyloid biomarker, screening for ApoE epsilon 4, I think, should occur. Should these patients all have neuropsychological testing? It probably would be my guess, if you were going to give the drug, and then genetic counseling prior to genetic testing, right? So people make major changes in their life based upon genetic testing now, and genetic testing is more available. There's 23andMe, and I couldn't even tell you how many mail-off genetic tests there are. Who should not receive Lecanemab? And this is from a consortium that was developed and a paper published in Journal of Prevention of Alzheimer's Disease. So participants with immunologic disorders not adequately controlled or requiring therapy with IVIG, monoclonal antibodies, immunosuppressants, or plasma exchange were excluded in Clarity AD. So other unstable medical conditions, including stroke, TIA, bleeding, or seizures in the prior 12 months were excluded. The patients with depression were excluded. Seizures in the last 12 months, as I mentioned. Presence of cerebral amyloid angiopathy-related inflammation or amyloid beta-related angioitis increase the risk for ARIA, and it's been discussed in this paper, and probably should be excluded. They recommend excluding patients if they're on warfarin, vitamin K antagonists, DOACs, direct oral anticoagulants, or heparin until more evidence. And then participants with clotting disorders are felt to be excluded, particularly those who have a predilection for hemorrhage. And they do allow patients in this recommendation who are on a standard dose of aspirin or basically Plavix. I'm not sure if we use these others very much. And then patients who are homozygous for the ApoE epsilon 4 gene or at increased risk for ARIA, and risk may be increased with antiplatelets. They didn't really say they should or should not receive the drug. They just said they're increased risk. And this is just, so MKS is my initial. So this is inserting my opinion into otherwise discussing the data. So I apologize for switching gears a little bit, but we're going to see patients who have had genetic testing and they're positive for ApoE epsilon 4, but there's no memory problem. We're going to see those patients. Moderate or advanced stages of Alzheimer's disease, of course, we see those patients. Any other causes of dementia, such as vascular dementia, and dementia is frequently mixed. It's frequently Alzheimer's plus vascular, and then they had a remote history of drinking or whatever. As if the patients had a prior intracranial hemorrhage, should they be excluded? Didn't specifically say with this committee. And then evidence of amyloid angiopathy on gradient echo, they did kind of address that, but they didn't come down firmly. So I have then another sort of postulate or question. If the patient's treated with Lecanemab and they present with acute stroke, should they receive TBA? And I think the answer is probably no. So essential questions are safety and efficacy. So that's the foundation by which we make our decisions, right? So we're either recommending to start something, writing for it, or recommending to stop something, usually as neuromedical clinicians. Black box warning and safety concerns, and I didn't because of time constraints, I didn't publish the entire black box. So the black box goes on to subcategorize in by committee consensus, it seems like, but not by other sound evidence, but subcategorizes mild, moderate, severe ARIA and stopping and restarting the medication. And then costs and insurance coverage, $26,500 a year. And there are insurers, I think, that are paying for this. Medicare, I believe, has said that they will pay for it. ARIA and other adverse events. And then there is, I think, concern about diversity, equity, and inclusion in the trials, and maybe exclusion of certain groups. Was there some recruitment bias? I think would be the. And I apologize for this not coming out, but this is a study from the Mayo Clinic that just was published looking at recruitment of participants who would qualify for Lecanemab. And they employed everything they could, the package insert, the risks and benefits, the committee's recommendations, so forth and so on. So out of 237, and MCSA is Mayo Clinic study on aging, I think, yeah. Out of 237, they kind of weeded it down and found 12 out of 237, about 5% of patients who presented with either mild Alzheimer's disease or mild cognitive impairment felt to be due to Alzheimer's disease that would actually qualify to receive the drug. So at U of L, we met and researchers and care providers of patients with Alzheimer's disease and related dementias recently, and we kind of decided to sort of hold off and not be the first ones out of the box for this. It was concluded there was a high risk of harm to the patient that exceeded benefit of the drug and delaying progression of early Alzheimer's disease, particularly in consideration of currently available less toxic agents. So it is true that the most recent oral agent for slowing cognitive decline was approved in 2003. I think that was galantamine. I'm sorry. Memantine. Okay. In any case, so I think that I will put on the table there's no right or wrong in this particular case. It's a balance, and all of healthcare, all of life is a balance. And so With that kind of postulate, I'd like to invite discussion among our guests, and I'd like to introduce Dr. Greg Cooper from Norton Healthcare, who I think has experience with this medication and knows the literature quite well. And I want to also welcome Dr. Chris Shields, a longtime friend, neurosurgeon with the Norton Healthcare Group, and an entertaining discussion.
All right. Well, so thank you all for having me here. I think that it is fair to have different opinions on this. I don't think there's any question about that. We have obviously taken a different view on this, and we have already started treating patients. We've got, I think, about 3 on treatment and another 20 or 30 coming in death, going through the steps to get on treatment. So we'll probably treat a lot of people, whether that's right or wrong, we will. And the stance we have taken is that the evidence is pretty, I think the evidence pretty well speaks for itself. Now, you can have different opinions about the data, but the data is what the data is. And to steal sort of the terminology on UCSF's website, Lecanemab slows progression by about 30%. Now, some of the outcome measures were as low as 23%, some were as high as 36%. The main outcome measure is 27%. About 30% is not an unreasonable number to put on that. The risk of symptomatic ARIA is serious, and I tell people that this can cause symptoms. It can land you in the hospital. It can even cause death. That's true. I think I would not be doing my job if I said that. At the same time, the risk of symptomatic ARIA was 2.8%. Now, if you're ApoE E4 homozygous, it's 9.2. If you're heterozygous, it goes down to 1.7. But overall, population study-wise, about 2.8%. Less than 1% ended up in the hospital. There were actually fewer deaths on lecanemab in the study, but there were 2 or 3 deaths reported after the study that were at least plausibly related to the medication. So I think it's fair to tell people this can lead to death. Now, so balancing that, my approach has been to have a very honest discussion with patients and their families about this, telling and trying to be as balanced as I can be. Here's what the data shows. Here's what's reasonable to expect. You're not going to get any better. You're not going to stop this disease. 30% is not a good number. And tell them the risk. So far, I have not had a single patient or family member that didn't find that meaningful. So, in my opinion, I feel an obligation to offer that to people. I wouldn't fault for someone for saying they wouldn't. You know, there are a lot of treatments in neurology that, frankly, I've been uncomfortable giving, but it doesn't make it wrong to give them. So that's the stance we've taken right along. And so far, it looks like the biggest problem we're going to have is keeping up with it. It's an enormously hard job to keep up with all of the screening, the safety monitoring, everything that goes along with it. So I'm a little intimidated by the list, but that's the stance we've taken, right?
Thank you, Greg and Mike. So the elephant in the room here is the amyloid cascade hypothesis, which is a fraud because it doesn't explain what's the cause of this disease in sporadic cases. And sporadic cases are about 99% of cases of Alzheimer's. Genetic cases that's something else entirely. But there is more than 10 years experience and more than 15 studies have shown that removing amyloid from the brain doesn't help the patient. These 2 new ones are different. The results are statistically significant. But there have been other studies that show it's not helpful. And we already know that the amyloid in the brain is not the main problem. So that about 1/3 of people at the age of 65 have amyloid in the brain and they're not impaired. They're cognitively intact. my 97-year-old aunt died without dementia, and she had a lot of plaques. That's very common. Carol Brain from the CFAT study and published in New England Journal and other studies have shown a lot of old people have a lot of amyloid, and it doesn't mean that they're impaired. And the opportunity for the placebo effect here is significant because the patients could have headache, or they could know that how come I'm being asked to have an MRI scan, unscheduled MRI scan, because they saw something on the other one and they want me to do one every 3 months. But my friend Fred, who's in the study with me, he hasn't been asked to come back for an extra study. So that the opportunity for placebo effects and also nocebo effects, if you're able to guess that you're not receiving the active agent, then you could have a nocebo effect. There could also be a placebo effect because of the investigators. If the investigator who is doing the study can tell, well, this guy's coming in. Let's see, we need to do another test on him because he's coming in. Why is he coming in? Because he had ARIA. So that there's this confusion of information which could help the investigator. There's a remarkable study which I frequently talk about by Rosenberg from the 1960s. It showed that investigators can influence the performance of an experimental rat. So they gave rats to different undergraduates and said these rats are very intelligent, and these rats, other students were told the rats were bred to be very stupid. And when the students did the testing, the stupid rats did not do as well as the smart rats, even though the rats were genetically identical. So that there's an enormous opportunity for that in this study. And what I find most astounding is the concepts. So Wilcox, the FDA commissioner who approved Lecanemab, said that, and I quote, "It's time to move beyond purely empirical evaluation of the data." So then she approved the drug, which didn't work. We know Lecanemab doesn't work. And she approved it because she thought the idea that it might work was more important than the fact that it didn't work. She's no longer with the FDA, but that was like, the Lecanemab is the most unsuccessful drug launch in the history of drugs in the United States. The other elephant is the atrophy. Atrophy is not good for you. So the Lilly and Pfizer have said, well, maybe the atrophy is because the amyloid is being removed from the brain. So they're kind of implying that the atrophy is, but I think atrophy is not a good thing. And other people have said that there isn't that much amyloid in the brain, so that if it was removed, it wouldn't cause atrophy by itself. And the prescribing information, which I received in an email from Lilly 2 days ago, no, this is about Lecanemab. It didn't mention atrophy. How could they not discuss this? And I was at the Alzheimer meeting in Amsterdam in July, and they had seminars about Donanemab and about Lecanemab, and they did not mention the fact that there's atrophy. And that is important. So I'm concerned that there are going to be families that are going to consider, what should we do about grandpa? We have this savings. Should we use it for grandpa, or should we use it to send a grandson to college? That would really be tragic for this. And this is taking oxygen out of the room, which could be used for other things. So I'm working on the influence of microbiota, which is another topic entirely, but it's promising in many different ways. But to fight this kind of enormous emphasis. So at at the Alzheimer meeting in Amsterdam, there were presentations by the chief scientist for Lilly, the chief scientist for Eisai about these new drugs. And I asked my question, if we knew what causes the disease, maybe we'd be able to get a therapy which is more effective than this. Maybe a therapy where we weren't arguing about is this a significant effect or not. And could they please address this question? What do they think is the cause of Alzheimer's disease? And these two very distinguished scientists, one guy said, oh, it's the amyloid. But we know that's wrong because many people have amyloid and they don't get impaired. And the other one said, oh, it's aging. And we know that's wrong also because a lot of people get to be old and 40, 50% of people at age 100 are not demented. So if we had an answer to this, this is like the fundamental question, what the cause of the disease is. Maybe if we knew that, we could get a therapy where we wouldn't have to be here arguing about whether it's significant or not. One other thing is, at the meeting where this data was presented, we could only ask questions in writing. We couldn't ask questions from the floor, because that way they could get to choose what questions they wanted to answer. I think this was highly unethical and a violation of basic academic principles that there should be free exchange of information. Because I wrote my question, could the effects be because of placebo effects? I wrote it down and then gave it to the moderator, and he looked through the questions and decided to answer some other questions. The other point is, if you look at these people on these papers, they're wonderful neurologists. I've known them for 40 years. They're being paid enormous amounts by the drug companies. So the disclosures mean they have to say, oh, I have been supported by Eisai and Lilly and Pfizer and Biogen and this and this and this. But what you don't know is how much are they getting. So if you get a very large, if you participate in a big study from a big company, it gives your university a lot of money, and some of that goes back to the investigator as indirect costs. So there, I'm not implying anybody is doing anything unethical, but it's worth considering how much these individuals are being supported by drug companies.
So prior to giving the drug, what sort of screening do you screen for ApoE, for example?
We do. So let me say a couple things. So first of all, just to be clear, I received no money from any drug company at all, in case anyone wondered. I have been a clinical trialist for 25 years. And so certainly my organizations have received payment for being in those trials. I've never received any of that money. But it may operate differently for universities. I never have. And I will answer your question, I promise. I will take one, I will disagree with one thing. It is absolutely true that a third of people over the age of 65 have amyloid, and a minority, and possibly a small minority of those people go on to have Alzheimer's disease. That is absolutely true, and I've agreed with that for decades. I don't think that necessarily means amyloid has nothing to do with this. I think it's entirely possible that amyloid is necessary but not sufficient. I'm not aware of anyone with Alzheimer's disease that doesn't have amyloid. And so, and I don't think that it's likely there is going to be a single answer. There are probably multiple factors that lead to Alzheimer's disease. And I'm not convinced there is going to be a single simple answer. But to your question, the process that we use. So it starts out with a clinical diagnosis. I have good old-fashioned neurology. I see somebody in the office, I take a history, I do an exam, and if they have a diagnosis clinically that appears appropriate, MCI due to Alzheimer's disease or mild Alzheimer's disease, then you go on to the additional testing. So I'll do an MRI scan, looking for evidence of superficial cirrhosis, microhemorrhage, etc. You have to do some marker of amyloid, and right now that's CSF. CMS has proposed that they change their rule on amyloid PET. So we'll probably be doing amyloid PET scans in the future. But right now, that's a CSF exam. And there have been people that I was 99% sure they had Alzheimer's disease. The biomarkers come back not amyloid. So clearly I was wrong. So you have to have some humility, and you have to do those tests to make sure that they have amyloid. Now, if they've gone through those steps, and we have a pretty serious discussion about the medication, and they want to go forward, and we even have an agreement to hold me accountable, that I've given them a fair review of all of the risks, and to hold them accountable. If they take this medication, they're agreeing to infusions every couple of weeks. That's a big deal. They're agreeing to safety MRIs before the 5th, 7th, 14th, and possibly other MRIs. So they have a responsibility as well. So we go through all of that, and we strongly recommend ApoE testing. Not required, but we strongly recommend it. We talked about this, and we are not referring them to a genetic counselor, but we do genetic counseling ourselves to help explain that risk. I was opposed to ApoE testing prior to this because I don't think it really tells me very much. It's different with these treatments. If someone is ApoE homozygous, then I tell them, okay, now your risk of symptomatic ARIA is 9.2%. If they're heterozygous, I'd say, okay, now your risk of symptomatic ARIA is 1.7%. If they have no copies of ApoE, I tell them it's 1.4%. It's 1.4 different from 1.7. But you at least have that discussion with them. And then we also refer them to financial counselor. This is covered by the FDA, but that means a lot of different things. That means some patients will pay $0, and some patients may pay $500 a month. And that's a big deal. So they need to know that. So we refer them to a financial counselor so they can tell them drug, infusion, MRIs, all in, this is what it's going to cost. So long-winded. Does that answer you?
No, I think it's great. It does sound like logistically very busy, lots of moving parts to monitor these patients.
So I will say, this is clearly smart people can have different opinions on this. I felt an obligation to do this. There have been many nights when I can't sleep that I regret agreeing to do this. It is a big deal, and it's not easy. That's going to be one of the reasons relatively few places are going to do it. UK is going to do it, we're doing it, IU is going to do it. But you're not going to see small private practices do it because it's just too big of a jump. And that really feeds into the whole equity part of it. There are serious questions about the cost and the equity associated with this. And that's beyond our discussion today, I'm sure, but those are serious concerns that we as a society are going to have to grapple with.
You don't need to exclude all the ApoE homozygotes.
We made the decision not to. We again, I think you can debate this. I tell people the risk, and I happen to think they and their families are smart enough to figure out what risk is acceptable to them. Now the VA, I understand, has excluded ApoE for homozygotes. I don't fault them for that. So we've taken the stance that we tell people the risks and we let them make the decision. I'm probably a little overboard on anti-paternalism. I think the patient deserves to make the decision, and I don't want to take it away from them. But I think I could be faulted for that. I think that's questionable.
Just to be clear, I believe amyloid in the brain is important, but it's not the main problem.
So we probably agree.
With that, did you have a question?
I have a question kind of about the MRI surveillance. You kind of mentioned like the initial MRI steps, but then let's say the patient's on all this different issues, how do you continue on?
So the appropriate use recommendations were monitored before 5th, 7th, 14th. If they're ApoE4 homozygotes, consider another scan at 52. Consider. After that, you probably don't need to do anything. It's felt that the risk is up front in those first 3 or 4 months. So, and certainly that's what we have seen with other anti-amyloid agents that I've been involved with, and that's what the trial showed.
If they're non-symptomatic, then are you able to do this?
If they have no symptoms and radiographically it's mild ARIA, then we will continue treatment, but we'll check an MRI monthly after that until it resolves or stabilizes. If they have symptoms or it's moderate and their criteria for that, then we hold treatment. If it's severe, we hold them from that.
You have 3 patients on it now, how are you doing?
But now, to be fair, 2 of them have had their second infusion, 1 has had 1 infusion, so you can't say much from that. Now, I was not involved in the Lecanemab trial. I've been involved with Aducanumab, and I happen to agree that probably shouldn't have been approved. So, but I've been involved in other monoclonal antibodies, and yeah, the experience is probably I've treated 30 people. So there's not. It's hard to make good conclusions there. I've never had a problem, but I've probably been lucky. If I treat 1,000, I'm going to have some problems. If I treat 100, then I have a good chance of putting somebody in the hospital. Not something I'm happy about, but that's probably. So I don't think we should undersell this. I don't think we should over or undersell. I want to try to be down in the.
Do y'all, so if a patient is receiving lecanemab and they come in, say, with a stroke,
Yeah.
do y'all give TPA? Do you?
We have made
coordinate
the
some-
decision as a group not to. So I've met with our stroke team, I've met with our physicians. We have made the decision not to. Now, the data doesn't tell us that that's how we should do it necessarily. But one of the folks that died after the trial was over, so they weren't included, that was not included in the trial. They died after a pretty massive hemorrhage receiving TPA. Now, I think all of us know that people die from TPA if they're not on lecanemab. So maybe that would have happened anyway. But these are early days, and so I think it is reasonable to be more cautious now. You know, back when I was a young kid training, we had a list this long against TPA contraindications, and now it's this long. It'll probably be a similar situation, but I think it's better to play it safe. So that's our. We're following pretty closely with Jeff Cummings' group that came up with the recommended use, AUR, or whatever that stands for. But that we're following their guidelines pretty closely.
Just as an update, Sowell Reports has a paper published last week that shows that the functional bacterial amyloid protein curly can cause templated misfolding of neuronal proteins and also enhance inflammation in the way that we have shown in rats and nematodes previously. And the beauty of the microbiota approach is that it may be similar for Alzheimer, Parkinson's, ALS, and PSP and other conditions. My favorite example about the question of etiology, somehow everybody has ignored this. What's the cause of these diseases? What's the cause of Parkinson's? And in the non-genetic case. So imagine why would an ALS patient get weakness in one foot and another ALS patient has trouble with their tongue as a first symptom? What is the theory about the disease which explains why ALS has these different presentations? Anybody who? I haven't heard any theory other than it's a random accident. Also, Prusner said the cause of Alzheimer's disease is a random misfolding of the amyloid beta protein. And I think that's highly unsatisfactory, conceptually unsatisfactory, that it's just something bad happens to you. But I have published that the different onset of ALS in different parts of the body could be because of where the interaction with the bacteria and the nervous system is taking place, in the gut or in the nose, in the mouth, or what part of the gut, which could lead to pathological processes in different parts of the nervous system. And if anybody would like to offer an alternative hypothesis, I'm happy to.
Tree markers with us down the road at the effect of microbiome, not only on the response of lecanemab. We think that the specific microbiome in the gut may have an effect of microbiome, as it did with that very important study on malignant melanoma. If you have a specific microbiome gut population, the response to treatment for multiple myeloma is positive. You get excellent results. You get the different microbiome. It's terrible. So we think there's a great relationship to the microbiome, and we're looking at that not only with lecanemab, Parkinson's disease, surgical outcomes of developing dementia and delirium postoperatively. So we've got big studies, multiple studies going on, and what I think you advocate is a very important part of people's lifestyle. Thank you.
Well, very good. I want to thank our guests, Dr. Friedland, Dr. Cooper, Dr. Shields. Thank you for coming. Have a great day. Thank you for your attendance.
See you tomorrow.